This case I'm presenting is the shoulder instability with the glenoid bone loss. So this was, yeah, 29-year-old male, IT professional. He plays football as a recreation. Right shoulder dislocated while playing football 2 years back, and close reduction was done in a local hospital by the emergency physician, and immobilizer was given for a week. He resumed sport after 3 weeks again, and he fell down. A very, very active guy, and he redislocated, and he has had 8 to 10 episodes of dislocation again, and now he's apprehensive, and that's disturbing his sleep, and he wants a solution for his problem. There was no sign of generalized ligament laxity, severe apprehension at 80 degrees and with attempted external rotation. Jobs positive, the biceps tests were negative. He wants to resume sports. So that was the X-ray. You can see the glenoid bone loss in the Bernagio view, the normal shoulder and the affected one, the anterior, that doesn't work, the anterior glenoid bone loss is evident there. We subjected him to an MR. MR-CT, we do both together. So you can see the anterior labrum tone and almost like an ulcer there, and that was the coronal image. You can see the biceps anchor well seated there, and the humeral head and the rotator cuff. That's the SAG session. You can see, you can stop that, yeah, you can see the anterior bit of bone loss there. So you have to quantify the bone loss before. It looks like a straightforward case, but then when we go through the guidelines, the right and the left shoulders, the 2D CTs, there, the anteriorly you can see on the right shoulder there is a blunting, while on the left shoulder you can see the ledge of the anterior glenoid well. There you can see the blunting of the anterior inferior. So you have to quantify the bone loss. So that's the 3D reconstruction. We got a good radiographer team who reconstruct this for us, the left and the right shoulders together. And that's the amount of bone loss the patient had, the best fit circle method and the Hill-Sachs lesion. So when we did the measurements, so that was a CT-MR report, the Bankert lesion, the rotator cuff normal, type 1 acromion, the biceps normal. The glenoid dia, when was measured from the other shoulder, was 25.4, the bone loss was 4.9, and the percentage of bone loss was calculated to be around 19.5, so that is at the brim. The glenoid tract was 17, and the Hill-Sachs index was 18.5, so that's an off-track lesion as the description goes. So we are at the brim, so now what to do on that? So everyone would treat this in one or the other way. So we discuss the option with the patient. So 19.5 bone loss and an off-track lesion. So you could put him as the fourth group of dislocators, or a third as well. So that's the bone loss, the on-track one and the off-track representations. And Provencher has said 20% is the cutoff, and he is just reaching there. So we had a discussion with the patient, and that's the paper which describes the on-track, off-track. The 4 type of dislocation, it was 25 originally. I've made it 20 after the recent papers. That was
Sujit, I'd like to interrupt you here. Which method do you use to measure bone loss? I saw the 3D imaging. What is your, do you measure it yourself, or does your radiologist do it for you?
Actually both. They do the measurements and give it to me. I counter check it. And if there is a doubt, we go and sit together and make a measurement. We always use the best fit circle method, or the 2 cross lines, the one in the center which divides, and always the opposite shoulder is taken as a reference.
Which software do you use for this particular measurement?
On the regular PACS.
On the regular PACS. So
do you on their console.
Okay. So do you use the 2D images or the 3D images?
3D images always. 2D images you could go wrong based on the cut you make. It's much radiographer dependent. So we always use a 3D image which will give you a visual impression. I can even counter check on Photoshop if I want. The number of pixels or the millimeters can be measured on Photoshop if you keep the zoom exactly same on both the images.
But what's the opinion of the house? Do they prefer a 2D imaging or a 3D imaging for this particular situation? Dr. Ashish, if I can ask you, for bone loss measurements, if you have to do it yourself, would you take the 2D images or the 3D images? The reason is there's recent literature which shows that 2D images have a far better inter-observer and intra-observer accuracy compared to the 3D images for the same
measurement, and then it affects our planning as such.
Yes.
Anything that is grossly 25% is blatantly obvious, you don't need a measurement for that. These borderline cases that are always dicey. Now, on our cadaver study that we published on the morphometry, our average Indian diameters were 25. That's why I raised my hand for arthroscopic Bankart remplissage, because this glenoid is 25.4 is good for me. Anything that is 20 and thereabouts is serious glenoid bone loss. So how you measure it depends. So the 3D is you must understand a reconstruction. It is virtual. It's not an exact. The 2D is always going to be exact, and you measure it at the precise length from the tip of the bottom. That makes a big difference.
In fact, in that paper, it was reported that 3D images overestimate glenoid bone loss by nearly 12 to 14%. Now, when that means a difference between doing a arthroscopic soft tissue reconstruction versus maybe an open or arthroscopic, I mean, let's face it, most people will have the skill set to do a good open bony reconstruction rather than an arthroscopic bony reconstruction. So it makes the difference for the patient between an open and an arthroscopic surgery. So the purpose of asking this question is, should we be measuring it ourselves rather than just blindly relying on what the radiologists tell us?
Jit, I have a question. Now, we know this classification less than 20, more than 20. So now, let us say your patient has got 12%, 16%, 22%, 26%. Are these figures going to make you decide, or the profile which you told? Athlete wants to go back to sport. So how would you make a difference between who is 16 and who is 22 with same profile? Will it change from remplissage to Latarjet, or it will remain same?
For a person less than 20, yes, my orientation would go more towards a bony procedure to give more stability, because the ligament laxity will be slightly more, the situ should be little laxer. So they can dislocate further in a younger age, maybe less than 30 and above 30 definitely, yes.
Same patient, your calculation is 16,
Okay.
and imagine the calculation is 23.
Okay.
So will it change your management?
Yes, it will. 16, I would like to orient towards soft tissue
For
procedure.
this patient, you would do a
Yes, he is
Bankart with remplissage.
26 and he's a recreational athlete. He wants stability. He plays mainly football, not a shoulder oriented
So
sport.
you are comfortable doing Bankart with remplissage for a
Yes.
footballer?
Yes.
At 16%
At 16,
bone loss?
At 26.
Okay.
For a person less than 20, I would probably err towards a bony procedure. Not at 16, but maybe 19, 20, I would, a percentage bone loss. Near 20% of bone loss, I would err towards a bony procedure.
No,
which
for
is definitely
16
more
what
taxing.
will you do? 16%.
16% bone loss, I would go towards Bankart
Bankart
with
remplissage.
remplissage. And my threshold for
Even
remplissage
if he is a contact athlete.
even yes, yes. For a person who's crossed 25, yes. For a very young person, probably a bony procedure, even for a bone loss more than 15. That is a subcritical bone loss.
So that's what I'm trying to highlight. These figures are not that important. Profile, patient's age, that plays on your mind.
Correct.
It is not the values.
Age and activity level. Do you use
Yes.
any kind of a scoring system pre-op for your instability cases? And if
Yes.
so, which kind of scoring? Which
ISI
scoring?
scoring system.
The ISIs, okay.
And shall we go forwards?
Yeah,
And
please.
about the measurement, I would like to make a note. Measuring ourselves, it will give only pixels on Medicine apps or the PAC software. But on their console, you can measure with millimeters. 3D
And
CT also.
Horos is a free software. And even in the bone loss measurements, there was a recent Australian paper which said that linear measurements again exaggerate glenoid bone loss. Area-based measurements, what is known as the Barchelon method, is said to be the most accurate because it subtracts the area from the glenoid, and that gives you a measurement with an accuracy of 2 to 3%. Even that overestimates.
So here I was confused what to do, whether to go for a soft tissue reconstruction or a bony procedure. We discussed with the patient and gave both the options. We said the Latarjet would be a longer procedure, more time consuming, more difficult for you, maybe a little more complication the first few weeks or a couple of weeks when you recover. But the patient said, no doctor, I want the strongest reconstruction for my shoulder, because as you said, it is near the critical bone loss. So we took the decision, and that was the confusion we had, whether to go for a Bankart with remplissage, as Dr. Ashish rightly said. I would have gone for that if the patient had given me the choice, because that's a much simpler and safer and faster solution for me. And this is a much more taxing solution. So Latarjet, yes, and remplissage, my threshold for remplissage is very low. So I feel we add another 10 minutes of surgical time, and you can exteriorize the exposed bone on the posterior superior aspect of the humeral head. So that is something which I just add just for the sake of it. I would say it is not indicated in this case, but then a remplissage also would.
Can I ask something, sir?
Yeah.
How many of you would actually combine a Latarjet with a remplissage? A bone block procedure with a remplissage?
There's nothing against. It's just
No,
adding a seat
asking
belt.
the logic. Why? The bone block is actually supposed to make the.
I'll cover it in my presentation.
Yeah, please,
Yeah.
both of you can give an answer to
Yeah.
that question.
Hello, why not is the question. So it's not going to restrict the movement. I'll show the post-operative range of motion for the patient. There's no restriction absolutely. And you are adding something more just for the sake of it or for the support of it. So you have a exposed piece of glenoid. There's an 18 millimeter Hill Sachs which is measured already there. And if you can exteriorize it without restricting the external rotation, why not add it? It'll give only added stability. It won't affect the results of the Latarjet anyway. If I were to do an open Latarjet with a remplissage, I would do the remplissage first. I would insert the anchors first because that would be a pre-operative planning. So I would insert the anchor, pass the sutures through the infraspinatus complex, and then open anteriorly and do the Latarjet, and then tie the remplissage sutures at the end.
So around 7% of patients do need it. I mean, the situation is such, but then,
Not this patient, yes.
no, I mean, of course not this patient. But then he was not sure. I mean, how many 7% patients of all the instability patients, how many surgeons would actually encounter those 7% in their lifetime, maybe once in a lifetime kind of a situation? And then he was not sure about the remplissage anyway. I mean, he was sure that probably I'll go for a autograft reconstruction of the humeral head at that point of time. So yes, theoretically it does exist, and you may encounter once in a lifetime kind of a situation, but then stick to the basics at that point of time, I think.
Yeah. So again, it is a matter of debate whether to do or not. But then there is nothing wrong in doing that. Just one anchor.
Absolutely,
Another 10
absolutely.
minutes, you're just giving another support. So we are not burning any bridges, and it's a simple procedure to be added on. So that's what I.
That was an excellent demonstration, but I think Raju has always shown some literature. So less than 20% loss, even ISIS, the cases where the risk is high, I think remplissage and Bankart, if you look at the long-term results, there is no difference. What do you say, Raju? You have some literature?
So yes, we'll be presenting the review of literature very soon, but then this is now presently open for discussion.
Yeah.
Clinically, yes, I mean, but then as he said, his player is a high-impact sports person, football player. It's a collision sport, so maybe it's warranted for that particular indication.
But I think there is literature for the high-impact sports also.
Let me answer that. The amount of bone loss, we started with 25%. That was 2014, Giacomo Itoi paper. And then Tokish published in 2015, I think, 14-15. Then that bone loss was 13.7. But that was in military recruits. And then further papers came with recurrent dislocation after Bankart with 10% bone loss even. So, but then this is the Provincius paper I showed now, which is 2020, where he said we'll strike a balance, and the right bone loss for critical subcritical was 20%.
If you look at the French literature, they do it for 0% bone loss.
Yes, but then that osteolysis. There again,
But that's why there are meta-analysis.
So this osteolysis thing, if it actually, the thought process that is coming, this is a elastic fixation, right? And if you do a rigid fixation, then the resorption rates of the graft are far higher. If you're doing an elastic fixation of the graft, this is rigid, but this is somewhat elastic. People are using buttons, people are using sutures. So this is not as rigid as the screw fixation itself. So probably the resorption pattern with this graft will be different from what one would see with a conventional Latarjet with two screws.
You're right on that, and the resorption is described on the outer periphery of the coracoid, and the new papers, I have some photographs after this, a small review literature after this, where it says that the coracoid tries to take, or any graft like a scapular spine or the iliac crest bone graft, will take the shape of the native glenoid. That I feel is because of the rubbing of the subscapula, which is a very strong tendon. It rubs and makes the coracoid or the bone graft into the shape of what it was designed to be. So if you keep an extra graft, it will osteolize more. And when
Yes.
there is a screw there, my concern is that screw head. When it osteolizes, the screw head become prominent because the bone is being rubbed and the metal will just stay there. So here that is negated. And when it's compression, as you said, it will allow more bone healing because of the micro motions, like in a
Routine fracture.
relative stability thing.
Thanks, Sujit. I think we'll present the